Just a little piece of information. 60% of the general population has never heard the word sepsis. And if you look next to you, 1 in 3 of you is going to be directly affected by sepsis in your lifetime. That's your mother, your father, your brother, your sister. 1 in 3 of you directly affected, and it's usually severe sepsis or septic shock. I can honestly say that 6 years ago I sent my husband to the hospital in severe sepsis. So this is one of the reasons why we have worked so hard to be able to get this stuff out there to you. So guess what? It's now time to do implementation. So how do we do this? Well, we need to understand what our current treatment process is. We need to identify the key members in our process, and we need to develop strategies to implement them and to improve the guidelines and track your outcomes. So, how do we identify the sepsis patient? Do we do it at triage? Do we have a screening tool that we use at triage? Some of the facilities use pull till full. Do they even stop at triage, or do they go back to the primary nurse? You need to know what that process looks like. Do you have just your provider assessment? Think about some of our small facilities that may have 9 or 15 beds and they may have 1 physician. How do you increase the interest of that physician to get in there and see that patient? Do you have clinical decision support? Joni's going to talk about clinical decision support. Do you have best practice alerts? Does your electronic health record alert you that this may be a change for this patient? And so we need to understand how that system works to identify where those gaps can be. This is called a process map. Now I know there's a lot of color up there. I know there's a lot of things going on, but really what this is you walk the process. You walk down and you go to the triage nurse. If I have a patient that has a high heart rate, a high respiratory rate, says that they've been running a fever at home, and has been coughing up green sputum, what are you going to do? Ask the triage nurse what she's going to do with that patient. You've already highlighted 3 of the SIRS criteria and a possible source of infection. That patient has sepsis right off the bat. Ask that triage nurse what they're going to do with it. She says, well, I'm going to do a set of vital signs and I'm going to get them to the back. Okay, so you walk to the back and you go to the primary nurse. This is what the triage nurse gave you. What are you going to do? You just ask those questions all the way along the process. Why? Because you're going to identify the gaps in your process. They're going to identify the areas where, oh, wait a minute, we don't do this part of the guidelines. We don't do this element. It helps you identify where you can work on your process and make it better for your patients. So that was just a high-level view of the process map, okay? It can be done in about 10 minutes. I did this in about 10 minutes because I wanted to time myself, walked all the way through JPS ER in 10 minutes, asked these questions and had an idea what I needed to do, what was different and what needed to go on. So how do we look at this? Well, we look at it to identify those areas where we need to look deeper. Think about it. If you say that to that primary nurse, she says, I'm going to start an IV and draw lab. Okay, what happens to it then? Does it go in the tube system? Does it go down the street to the lab? Does it go to a stat lab in the ED? Does it do point of care at the bedside? What do you do with that blood? What do you do with that lab? How long does it take you to get turnaround time to get results? Is it done the same way every time? Now, I'm pretty sure that if I went to THR and if I went to Baylor and if I went to JPS and I went to a large hospital, I would probably have a pretty quick turnaround time. I'd probably have a pretty good process. But what about our smaller facilities? What about our Waxahachie's, our Rockwalls, our Azle, our Cleburne? What about some of those smaller facilities that don't have all of those things? Well, we needed to discover a way that we could implement the guidelines in a hospital regardless of the size and regardless of the facilities available. So is it done the same way on nights and weekends? Think about your night weekend staff. They have the least resource of anybody available. We want them to have the same ability to trigger all of these things. We need to clarify the people that are involved in our process. How many of you would realize that respiratory plays a huge role in your process, as well as pharmacy, as well as lab, as well as radiology? They all play a process in this, so you need to make sure everybody's there. It helps you, these process maps help you identify areas where you have delays. If you're waiting 90 minutes to get a lactate level back, and that's part of your 3-hour bundle, half of your time is gone. If you're waiting 60 minutes to get a CBC back just to find out what a white count is, you've lost a third of your time. So think about all the areas where you can have a delay. What if your tube system is down and your lab is across the street and down a block? Think about all the things that you can have as a delay and work those into your process. Do you have provider delays? Do you have a provider that's great at going in and doing assessment, but getting him back in there after lab's back and stuff to do a reassessment is almost like pulling teeth, going, you've got to reassess this patient. Think about all the elements where those providers and those ancillary departments can fall down. You may be the best sepsis nurse out there, but remember, you have to have a team behind you and a team working with you for the care of this patient. How many of you have ever taken a patient from the ER to the cath lab to the ICU and discharged them home by yourself? Yeah, kind of thought so. Remember, it's a team effort. So who owns these processes? Is it nursing? Well, we as nurses do the majority of these elements. Is it the ED nurse? Well, she's responsible for that first 3 hours of stuff going on. Depending on how long your time in your ED is, they may be responsible for the 6 hours. National average for sepsis patients in the ED is about 6.5 hours. So that pretty much says that the ED nurse is going to have to own part of that. But what if you're one of those facilities that can actually get these patients out, get them upstairs to the ICU or to whatever unit they're going to in 3 hours? Well, your ICU is going to have to own some of this because why? They're going to be responsible for that 3 hours. So you have to think about all the people that are involved with that. So is it administration? Is this an initiative from up above that says, I hereby bless you to make this work? Well, CMS kind of did that. They kind of came down and said, guess what? You're all going to report. First reportings were anywhere from 9% compliance up to 69 to 70% compliance. Those facilities that have taken this seriously and have been working on it for several years, they're the ones in that 70 range. Those that have kind of sat back and said, oh, this will go away, this too will pass, yeah, they're the ones at the 9%. Is it owned by quality? Is it owned in their realm? Are they the ones that are dictating it? Chart abstraction, quality measure, it's a quality sepsis measure, so do they own it? Who owns it? Do you have a sepsis coordinator? Are you lucky enough to have a sepsis team that are owning this and looking at all of the different variables and getting that education out there and getting the training out there? Is it being provider driven? Is this written into their contract? 80% of the time they will be correct, and 80% of the time they will have done the care bundles when that was recognized. ED, ICU, hospitalists, think of how many people have to be on this team. Is that a provider quality metric? We're starting to see this being written into a lot of these physicians' contracts, so they're going to be interested. How are we doing? How do you know how you're doing? Well, let's see. They didn't die. Is that good? Is that bad? Yeah. So, are we on track? Ask yourself, at my hospital, are we on track? How do you know? Are you stuck at the station? How do you know? Look at your process map for gaps. Assessment. Do you assess at triage? Do you assess in the back? Where's those assessments taking place? Is it nursing assessments? Is it physician assessments or provider assessments? Are those reassessments taking place? We're looking at test results. I talked a little bit earlier about having those delays in test results. I can honestly say that in facilities that I've worked and in other facility people that I have talked to, it is not unusual for 45-minute delay in getting a lactate level from the time of arrival or zero time till you're getting that first test. Think of how much time is lost. Is there a way to make that process faster? Is there a way to get those results faster? How can I make this so that I have all the information up front for my physician to be able to make a decision? Is it on that reassessment? Oh, reassessment. Those of us that have worked in the ER for many years, we always have those doctors that are right in there and that are reassessing, and those other doctors that you cannot get them to go back and finish up a patient and make a disposition. We're talking about emergency patients. We're talking about putting these patients on the same level as that stroke patient, as that STEMI patient. These are those patients that are at that same level. We talk about the golden hour of trauma. This is the golden hour of sepsis. Can you get them in? Can you recognize them? Can you get a lactate? Can you get the blood cultures? Can you get an IV or an antibiotic started? And can you get fluids on board? Because remember, the only antibiotic that is going to do the most effect for this patient is the first one. How fast can I make that happen? Do you have metrics for this? Do you know where they are? Do you know what they are? How do you get a hold of them to be able to say, are we doing better? We saw that Chris had showed us that she had some metrics that are going up and down. What do they tell you? Can you look at them and read them? Who collects them? Is it the quality people after the patient's been discharged? Is it your sepsis coordinator who does it on a daily basis or an hourly basis as those patients come in? Is this something that is done monthly that comes out after everything has been done? Can you change a metric on a time frame 3 months later? Does it do you any good to see that your lactate took 45 minutes to come back 3 months ago? No, you need to have those metrics much more frequently, much more readily available and easy to read. And what's done with them? We are doing really good. I'm at the staff meeting and I say we are doing really good on sepsis, and then I move on to the next topic, and now we're going to have a turkey toss, and now we're going to have a fundraiser, and we're going to gather food for this. What did I just tell you? Did I give you any information? Did I give you anything that you can take back and you can work on and go, you know what, guys, we really sucked on these times. We have got to get better. We have got to move forward. How can I make it so that you guys know that? How about a metric? How about something that you can look at? You can look at as you glance by it. You can look at it on a dashboard. You can look at it somewhere on a wall that says, this is what I need. My first one there says time to lactate resulted. Every one of those variables I can go back and look at and go, oh, why did we have trouble with this one? Well, it was because we had 2 traumas in at the same time, and the one respiratory therapist didn't get the lactate level run because they were intubating 2 other patients. What other options do I have? That's when I have to step back to that and go, what are my second option? Time to cultures drawn. Remember, these are all things that we're doing in the first 3 hours. So when I started my IV, did I get my cultures drawn? Did I document that I started my IV and I drew my blood cultures? Or did I forget to document that I started the IV, drew the blood cultures, and then hung my antibiotic, scanned it into the system, and now my antibiotic shows before my blood cultures? Those of you that are in quality, I'm sure that has never, ever happened to you before, has it? See a lot of head nods going on. Remember, nurses work in a flow pattern. Give them something that they can flow with. Okay? Where are these metrics put? Where are they placed? Can you see them? Can your staff see them? Do you have them at your monthly meeting? Do you have them at a weekly meeting? Do you have a group of people that are working together on this for sepsis? So if you're going to implement change, you have to decide who is going to be on that team. I need an executive champion. I need somebody from the C-suite who understands what I'm driving for. I want to save people from sepsis. I am tired of young people dying from sepsis. I'm just tired of it. We were tired of people dying from trauma, and what did we do? We have trauma nurses, we have trauma centers, we have trauma education, we have ATLS education, and where's the sepsis education? As many people die from sepsis as die from acute MIs. Do you suppose the American Heart Association said, oh, well, people die? The stroke patients, think about them. This is where sepsis needs to be. Sepsis needs to be in that C-suite. It needs to be on the strategic plan. It needs to be a focus, because why? Between 30 and 50% of severe sepsis and septic shock patients die. By the time we get done with our program today, 6 people in the state of Texas will have died from sepsis. 3 people every hour die in the state of Texas from sepsis. I need champion providers. I need an ER doctor. I need an ICU doctor. We've got Dr. Sheehan. She's an ICU doctor, and she's right in the mix of it. Why? Because it's important. You need to make sure that you're working on that peer-to-peer level. Those physicians, I can go to a physician all day long as a nurse, and they're like, yeah, well, I'm the provider. You know what? I'm an advanced practice nurse. I'm a provider too, and I got doctor on my name too. So now we're equal. Let's talk. Okay? Nursing champions. Think about it. As you're looking at those nursing champions, you have to have somebody in the ED. You need to have somebody in the ED who owns it, whether that's a sepsis coordinator, whoever it is, and they have to own it. They have to be the person that's going, this is a sepsis patient. We need sepsis education on our skills days. We need more sepsis education. We need to be able to trend what our sepsis patients are doing. How are we doing on blood cultures? How are we doing on antibiotics? Own it. You need somebody in your ICU, because remember, if you're going to transition them to the ICU quickly, they're going to own part of that process too. So you need at least 2 of those people on there. And you need to make sure that your lab and your radiology and your pharmacy and your respiratory and your IT people and your nursing supervisors are all in on the process. Remember, what happens if a patient becomes septic on the floor? It's not the ER nurse that's going to have to do the recognition. It's that primary nurse. And where's her backup? MET team, rapid response team, code sepsis team. Where is their response? Where is their help? Think about when you're in the ED and you get a call from EMS that says, I'm bringing in a full arrest. You've got a doctor, you've got a respiratory person, you've got pharmacy, you may or may not have lab, you've got 1 or 2 nurses and a tech all ready to get that patient. What happens on the floor? I got a patient that's going into septic shock, and you can hear the crickets chirping, can't you? Where is their resource? So utilize those rapid response people. Guess what? They need education too. They need to know what sepsis is, what to recognize, and what needs to be done. Okay? So think about all the people that need to be on that team. And so as you're developing your plan, do you need to make big changes or do you need to make little changes? Well, gather your data, research, and your metrics. That will tell you, am I already following the guidelines? If you are, great, absolutely wonderful. But where are your metrics? Are they visible? Are they able to get out to the people that can really affect those metrics? Do you have team roles? Do you already have a sepsis team, but it just isn't going anywhere? Maybe you don't have the right people on the team. Maybe the right initiative isn't coming down from the top. Okay. Review your data and set your goals. Remember, Rome wasn't built in a day. You are not going to change your sepsis mortality and plan tomorrow. But you can make the efforts to go, I need to gather some data. Think about all of your millennials right now. They want to know data. Where's your numbers? We're teaching our physicians and our providers, data drives change. So let's get our data out there. Build your project plan with milestones and dates. You can't just say, I'm going to do a sepsis team and throw it out there without anything. What milestones are you going to complete? What dates are you going to have them done by? And implement it in phases. Remember, when we did a process map, where did we start? We started with that person walking in through the ER. Well, think about all the different access points. Is it any different if they come in by ambulance? Is it any different if they get sent over from a clinic? Is it any different if they go to OB triage? And in the case of JPS, if they show up in our psychiatric triage, just because they're crazy doesn't mean they can't be sick and crazy. It's okay. So build it, implement it in phases. Start out and go, I want to fix the first 3-hour bundle. I want to fix the bundle of 3 hours. That's your lactate, that's your blood cultures, that's your antibiotic, okay? Then go on and say, I want to fix my fluids. I want to make sure that my patients that come in that are hypotensive or have lactates greater than 4 are getting that 30 mils per kilogram right away and not sitting back waiting. Because remember, mortality increases 8% every hour that sepsis is not treated. And every organ dysfunction adds 20% mortality. So if this patient comes in and they already have COPD and they're coughing up nasty green sputum and they're running a fever, their mortality is already at 28%. So let's sit on them for an hour because this is just COPD. And let's sit on them for another hour because you know what, we'll get a blood gas then. And we'll get a blood gas, but we won't get a lactate level because if we get a lactate level, then we got to treat it. Do you need to do little changes? Do you need to just do some rapid cycle? Is it something that you're looking at going, oh look, our lactates take 45 minutes and we want to get that down to less than 30? Is it one part of the process that needs changed, or is it the whole process that needs changed? Tweak your current process to meet those guidelines. Or tweak your current process to include your metrics so you can start pushing forward and going, this is how long it takes to get a lactate. This is how long it is from arrival to blood culture. This is how long it is from arrival to antibiotic. Remember, we have a trauma program that says we want to get our trauma patients out of the ED, assessed and out of the ED in 2 hours. We want to get them out of the ED and to surgery in 30 minutes. We want to get our cath lab patients to the lab in how long? From door till cath? Less than 1 hour. How about our stroke patients? Door to needle? 45 minutes? What about our sepsis patient? Let's sit on them and wait. They'll get better. We'll start a little bit here, a little bit there. They'll get better. These are just as sick, and unfortunately, these patients die. So we built some steps into the sepsis guidelines. Joni went through the guidelines. Dr. Sheehan and Cam went through the guidelines of how to look for those patients. Now, I tried to put this into a swim lane, but it was like 4 slides long. So I stripped it down and put it in and said, these are the steps we're going to look at. We need to have some way to initiate a sepsis screen or alert and triage. We got to know up front. Remember, you have search criteria, know up front. Provider is notified that this is a possible sepsis patient. Remember, that's that handoff, that's that communication. Assessment of the patient gets in, release and implement orders. Think about this as these 4 elements, that is the first 15 minutes of arrival. That's what I want to happen in the first 15 minutes. I get some vital signs, we get a nurse's assessment, we get the physician notified, I get him in there, he writes orders, and we're moving forward. I now have 2 hours and 45 minutes to get all the rest of the stuff done to meet the 3-hour bundle. But what if this patient is really, really sick? Okay. Next step, reassessment and possibly new orders. Remember, I'm reassessing every time. Cam told us, we give fluid, we reassess. We do a treatment, we reassess. Implementation of the 3 and 6 hour guidelines. If I haven't drawn blood cultures, I need to get them before the antibiotic. Consider a central line. If this patient is going downhill fast, I need an access point to give fluid. I need some way to give a vasopressor because we really don't want to give Levophed in a peripheral vein if we don't have to. So I need to get a central line. Consider that higher level of care. That ER doctor and that ER nurse want to get that patient out of their ER faster than you want to take them. Believe me, after years of being in the ER and years of being in the ICU, it's okay. They want to get them out of a chaotic situation up to where they're going to get one-on-one or 1-to-2 care. Coordinate transfers and admissions and get that patient admitted as quickly as possible. Think about that. That's all that has to happen. That doesn't seem like a lot. That's only 10 things that have to happen. You've got 6 hours to get all 10 things done. Wow, that's a long time. What about that patient that's on the floor? Call your rapid response or your MET team. What if you don't have one? Who is your resource? You're at Azle. 68 beds, 85 beds. You suppose they've got a rapid response team? It might only be the nursing supervisor and a nurse from the ER. But call for your resource. Remember, on the night shift, that may be the only help they're going to get because they're running thin. Get the response from that team, get that patient assessment. Guess who's going to go up and assess that patient on the floor? It's going to be that ER doctor. So now I've pulled my ER team up to the floor. Implement some standing orders. If you have those patients that could possibly be septic, think about it. If I haven't had blood cultures in 24 hours, I can draw those. My patient may be on an antibiotic already, but if they are not and they become hypotensive, do I have a bolus order? Can I get a bolus order? Can I get something started until I can get more help there? Documentation of that and review that patient and documentation. Who's going to look at this patient for treatment plan if we don't move them? Or if we move them from a med surg to the ICU there, who's ever going to go back and look at it? If you put all of your eggs in the ER basket of seeing those sepsis patients, this patient will be missed because they went down during their stay. They weren't an ER admission. They say 60% of patients that are septic enter through the ED. Where's the other 40% come from? They're already in-house. So you got to think about both sides of the coin. So what I did build for you and what I put out and is available from the DFW Hospital Council, this is called a RACI chart. Over here on this line, we'll have all of the 10 elements, plus it'll have the inpatient elements. Right here are the benefits of why we do each one of those things. And here are the primary people that you need to have available on your team, whether you're on the day shift, whether you're on the night shift, whether you work at Big Baylor, whether you work at Cleburne. Okay? These are the people that you need. You need a primary nurse in the ED. You need a provider. You need a rapid response team, emergency team, critical care team, maybe nursing supervisor. You need a tech. You need somebody who's going to play the pharmacy role. If you don't have pharmacy 24 hours, who plays that role after hours? That may be that nursing supervisor wearing several hats, but at least you know that ahead of time. You need to have somebody from respiratory therapy. There's your nursing supervisor. I put plain sepsis here because I don't know if you have a sepsis coordinator, if you have a quality person that handles your sepsis stuff. That is your documentation and your inpatient nurse. Each of those have a role. Some of them wear more than one hat. Some of them have greater opportunities to be able to function more in a variety. I can tell you that where I work at JPS, we have a code sepsis team. When that code sepsis goes out, either I or Julie responds to the ED if we are in-house. We help those providers make sure, did we get our lactate? Did we get our blood cultures? What antibiotics have been given? How much fluid has been given? Where's the possible source? And we get that information up front. We look for those reassessments. We go back to those physicians and go, hey, you didn't put in capillary refill. You didn't say what the skin looked like. And so you can match up those pieces of information in that realm. But they're not going to have that at Rockwall. They're not going to have that at some of those other areas. That's why you have to have some ownership. Who owns this part of the process and who owns this? But this whole chart is available for you, and it really just tracks down and says who is accountable, who's responsible, who's consulted, and who's informed. And I put all of that information on there so that as you build your plan, you tweak your plan, you move forward in your implementation, it's going to get there. So these final touch points are going to be: understand your current process. Identify what you want your future process to be, and that becomes your roadmap. That is your plan. How do I get there? It may be 5 elements to change, it may be 1. Recognize that sepsis is a team effort. You have to have the people on your team. Champions and stakeholders play a vital role. And you have to use metrics to drive your process. I can tell you we do a great job of sepsis. But what does great really mean? Does it mean that I saved 50% of the patients? Does that mean I got my blood cultures 50% of the time? Give me some metrics I can work with. Show me where I'm improving, because every one of us wants to improve. Tell me what I need to do. Is it decreased time? Is it increased compliance? What do I need to do? Because metrics are a universal language. Everybody can see them, everybody understands them.